Thanks very much to the organizers. I know I'm standing between you and drinks, so I'm going to start with my conclusions, um, which are follows. If this consortium has a goal of expanding the understanding of human disease throughout the world, then there'll be an important need to meet where there are large gaps in evidence, particularly in South Asia, but also affecting Africa, or if you think of large countries with something like 100 million people, where information is needed eventually on the contribution of environmental and genetic factors. The broad strategy that we're outlining in India, which involves doing nationwide mortality studies that are representative of the population, to try to identify key questions that then can be pursued with prospective blood-based epidemiology might well be relevant. So I'll give you some preliminary data from India in terms of what we're finding. And the first conclusion is there are extraordinarily large variations in disease and the types of disease within India. Second, vascular mortality is the leading cause of death globally and in India, and there might well be important and so far unexplained novel risk factors, and I'll go through a few of these. And lastly, I'll describe very briefly Rajesh Dixit's prospective blood-based study called the Indian Study of the Health of Adults, or ISHA. Well, there's extraordinary diversity in disease in India. That was well known, but prior to the work in the Million Death Study, the cause-specific contributions and the age-specific contributions were not well known. So on your right, you can see the variation in child mortality showing a north-south gradient. That's been well described. And if you look at the main determinants of that, for example, female literacy levels or access to immunizations or treatment with oral rehydration, about 80% of that variation north and south can be explained. But look at adult mortality, 15 to 69, shown on the right. It shows, interestingly, an east-west gradient. And then if you look at known determinants of that, for example, local levels of literacy again, smoking, alcohol use, only about 30% of that variation across the parts of India can be explained. And we simply don't know what are some of these key drivers. We do know that it's driven by not just vascular disease, but also some chronic infections, notably tuberculosis. Well, to try to get an understanding of these patterns of deaths in India, a novel solution was needed because deaths in India, as in some of the other places I mentioned, don't occur mostly at hospital. They occur at home and without medical attention. So about 15 years ago, in the absence of good medical certification, we started with some support from the US NIH, the Indian Million Death Study, which involves working with the Registrar General of India, who have an ongoing demographic system called the sample registration system. And effectively, we use this to take a sample of all of the deaths that occur in India. Non-medical staff knock on the doors. They fill out a standard 2-page form and includes a half-page local language narrative. And then this is converted to electronic records, and we've got 400 doctors coding online. Each record goes to 2, and there's a variety of quite rigorous quality control efforts. And the goal was to study all diseases, keep things within the government, and keep it cheap. And so far, we've got about 800,000 deaths studied, and this solution now is being replicated to parts of Africa. Let me focus on what we found on vascular disease. So first, it is the leading cause of death, about 1 million deaths just in middle age, at ages 30 to 69, with ischemic heart disease being the dominant of the two. And interestingly, a large proportion of those that died reported a prior history, which is relevant for secondary prevention. Between 2000 and 2015, the risks of vascular or ischemic heart disease mortality rose in men and women, and stroke fell slightly. And this is shown here at all ages. You see in around 2000, India, the US, UK had comparable age-standardized ischemic heart disease mortality in men and women, but over time there's been quite a marked divergence. Stroke has shown a decline in all three of those settings, but Indian stroke rates are three times that of that in the UK or the US. Interestingly, the stroke patterns are also quite distinct, that in the northeast of India, representing Assam and the northeast states, West Bengal, Orissa, Chhattisgarh, these northeast states, they have about a third of the strokes of the country, although they only have a sixth of the population. And curiously, the stroke patterns or the trends in those high burden states behaves very differently than in the low burden states. So in fact, in rural areas, stroke burdens are rising in the high burden states, and also somewhat up in urban areas as shown in the dotted line. But in the low burden states, both urban and rural stroke rates are rising. And ischemic heart disease, interestingly, is rising greater throughout India, but mostly in the rural areas, not so much in the urban areas. Again, not what you would have expected. It points to the need for understanding risk factors and access to treatment. And this is showing the age-specific patterns, rising rates at each age for ischemic heart disease nationally, for stroke in the high burden states, but falling age-specific rates in the low burden states. Now, what's going on in here? Well, we need to understand some possible risk factors. Now, the well-identified risk factors certainly are important in India: smoking, blood pressure, blood lipids, but there are emerging risk factors, particularly around low body mass index, as Emmanuel was pointing out. And these need research. There might be a role of particulate matter, and I'll show you some preliminary results about ambient particulate matter exposure. Well, the first, to think about body mass, is to start with a understanding that the BMI distributions vary greatly in India based on literacy. That you see these startling different distributions. Among the illiterate populations, the prevalence of being underweight, meaning a BMI less than 18.5, is considerably higher in men and in women than among the literate. And as Emmanuel had pointed out in Dr. Gaja Lakshmi's work with Sarah Lewington and others, has shown that in the West, in North American Europe, there's a U-shaped relationship of body mass with cardiac mortality, but in South India, it's really flat. So there's two possible things going on here. Either there's some hazardous exposures at low BMI that are raising the risk of cardiac disease, or there's a protective effect that offsets the higher blood pressure that would be expected at higher BMI. Our evidence suggests that it's perhaps more the first. And I'll walk you through that by pointing to a somewhat peculiar but relevant exposure, which is lacto-vegetarianism in India. Now, diet is a very difficult area of epidemiology, but lacto-vegetarian is a unique exposure that can be studied well in India because people have been lacto-vegetarian pretty much their whole life. And you see this distribution that's mostly lacto-vegetarianism in the west part, and along the coast less so. And these tend to be lifelong lacto-vegetarians. And what do we find? Well, interestingly, there is no reduction in overall mortality for being a lacto-vegetarian, either as a man or a woman. And in fact, there's a slight excess as men of cardiac disease, but the same in women who are not wives, but curiously, a notable increase, 35% excess risk in wives. Now, why should wives be different? Well, this very much reflects the dietary patterns in India, and in a related study, we were able to look at whether it was the underweight themselves by the wives, which is in greater proportion than in not wives, that was contributing. And men eating first was an established risk factor in wives, but not in non-wives. And in women, it was an overall risk factor. And this is adjusted for the other exposures. And similarly, this earlier adjustment includes taking away the effects of smoking or drinking. So there are novel risk factors that certainly need to be explored versus low birth weight. Now, one of the other recent conjectures is, well, India's the second most polluted in terms of air pollution country on Earth. Is that playing a role? So you see the distribution of satellite-based particulate matter of 2.5 micron length here, and that's well concentrated in the north of India. So what we did is we spatially joined by geocoding all the million death study areas and looked at the risks comparing ischemic heart disease, chronic respiratory disease, stroke, stratified by the high and low burden states, to injury controls, and doing this very carefully. And the conclusion is that chronic respiratory disease does seem to have an excess, but not when you take into account that it's also spatially clustered in the same places as in the north. Heart attack is a modest risk, but even more modest once you take into account the spatial clustering. And stroke has a very interesting pattern. Really no association of particulate matter with stroke in the low burden states, but in the high burden states, there is an association, and it doesn't make much of a difference with spatial adjustment. Now, what this means is, first of all, that the modeled estimates, such as done by the global estimates for mortality measurement, the air pollution group, and the global burden of disease, have been applying Western relative risks to Indian exposures and getting rather colossal rates of disease, particularly heart attack and stroke, attributable to PM 2.5 in India. And our estimates suggest that it's quite a much lower than that, although there's real uncertainty in the estimates. Okay, what about a classic and important risk factor? Well, in Western populations, it's now established that a typical smoker will lose about a decade of life if they start early and don't smoke. And in Indian men who smoke cigarettes, there's a comparable loss of life. And again, this was a surprise because Indian men start smoking later in life, they smoke fewer cigarettes per day, yet they still have these very large risks. And these risks have become more extreme over time. Black represents the more recent follow-up, and white the earlier follow-up. And here you see the risks for most conditions have become more extreme over time. So to understand these carefully, the observational epidemiology I've described has limits and requires careful prospective studies that do include blood to be collected. And this is Rajesh Dikshit's Isha study, and in Barshi, where the work has started, 200,000 adults have been enrolled. And this uniquely involves a household enrollment. So it is actually representative of the areas. So teams knock on the doors, they get some questions answered. They're invited to a clinic where they undergo biologic measurements similar to Zhenming Chen's Kadoorie study measurements. It has a complete electronic data collection with a resurvey after 3 years. And it's designed very closely with the UK Biobank and the Kadoorie study to ensure interoperability. And the plan is to try to get about 1 million Indians enrolled in different parts of India. This work has already started in Solapur, and will start soon in Goa, in Varanasi, UP, where the current Prime Minister is from. There will be another cohort set up. Guwahati Northeast in Assam has those very interesting patterns of stroke that need to be mentioned. But so even with these existing sites, that doesn't quite come up to 1 million, and there's a need for about 2 to 3 more sites in different parts of India where there are unique patterns of disease. The follow-up will also be a challenge. Unlike the ability to link to routine records, for example, in the NHS, this will require active follow-up, including a resurvey every 3 years and linkage with various death registers and with the national ID card, as well as with the health insurance cards. And the hope is that India will undergo the revolution that China did with the linkage to the national ID or the national health insurance number, and get much better phenotypic information on the outcomes. And certainly mortality, it can get good, robust information using the verbal autopsies. So in conclusion, India is a place to do very interesting, diverse epidemiology. It has very relevant risk factors, particularly low body mass, that might well be of global importance, and can probably put some better estimations on things we take for granted, like particulate matter and heart disease, to better study those. And interestingly, we did hear some concerns about representativeness of blood-based epidemiological studies. The design so far of ISHA has been that it will be representative in each of the areas in which it works. Thank you very much.
I think we have time for a question.
One question.
Can I ask your stroke subtype?
Yeah, you can't get stroke subtype on verbal autopsy. You can't distinguish hemorrhagic or ischemic.
Yeah, in 1960s, Japanese has a high blood pressure and low cholesterol. That explains curious patterns of stroke. So maybe subtype is very important.
Subtyping would be useful.
Another question over there.
Just a quick thought on some of these regional differences. That in a place in India, like India, where there's a rapid transition in the epidemiology, it doesn't happen the same across the country. It happens differentially in rural versus urban.
Yep.
And if they're in the third phase, they're in a phase of rising. First stroke and then CHG, and then fourth phase in the epidemiology, in the transition in the urban, it might be falling. And that might explain some of your BMI differences as you're moving out of pestilence and famine. It's a good thing to be gaining weight. But if you're in the later stages, then gaining weight becomes a bad thing.
Well, I think we need to know enough about the different types of BMI progression. So when you're adding on lean muscle mass, that probably has different impact than when you're adding on fat. The urban-rural differences are a surprise, for example, and that might well reflect some access to, for example, statins, which is poor, but really poor in rural areas, but very limited access in rural areas. Again, that was a surprise, because you think, well, you go to the urban areas, you become fat, that's when your heart disease risk goes up. So, but it's going up, mortality is going up more in rural areas. So I don't know, quite frankly, what is going on with these explanations.
Yeah, but that's happening globally. You know, you're seeing the acquisition of cardiovascular risk factors even in rural areas.
In rural areas also.
Yes, yes. Okay. Diabetes. You go to Nicaragua, you'll see diabetes in rural Nicaragua. And you begin to see falls in some of those risk factors in the urban area.
Yeah.
Philip, you have a last question?
Yeah, it's not terribly important, but I was just wondering about the quality of the PM2.5 satellite imaging data. I mean, do you have a sense of how the geographic and temporal and seasonal resolution there, and maybe is it good enough for these types of analyses?
Yeah, I think the global PM2.5 community, the people who measure the satellites and the ground stuff, have done quite an amazing job. Their measurements are getting better and better. And these correlate, for example, at a 0.81 with ground-based satellites. Now that's annual variations. When you look at more daily variations, or for example, monthly peaks, such as occurs in January, there's less of a correlation with the satellites. And that may be where epidemiology needs to go. So the satellite measurements, I think, have really improved. What's not improved is the use of these relative risks from the GEM or the GBD, basically somewhat being indiscriminately being slapped all over the world to get these colossal estimates that really have had so little direct evidence to back them up. So our study is going to be hard to publish, because guess who's reviewing all of these findings? The same ones that don't believe our numbers.
Okay, thank you so much.
Thank you.